There you go. Ladies and gentlemen, welcome back to Adherent First and 15. Welcome 2020. I'm very excited to start this whole segment. This is the third segment by introducing some news. In fact, we will collaborate more actively also with the American Rhinologic Society. And due to the fact there are more news are coming, I would like to introduce you the first speaker for this segment, who is Dr. Joshua Levy. Good morning, Joshua.
Good morning. How are you?
Good, thank you so much. And well, Joshua Levy is part of the Emory University, and he's collaborating with me since 1 month. So we are developing some interaction just to make sure that the American Rhinologic Society, the juniors especially, will interact more with the association, and we will be able to make some connection also with the European Rhinologic Society, the Italian Rhinologic Society, and all the scientific partners that we have. But by saying that, I would like to just leave the torch to him. Today's topic is going to be empty nose syndrome. So I will leave the torch to him. He will discuss the whole news about that. Please do remind for all the attendees that the questions should be asked at the end of his talk. Please.
Thank you so much for the opportunity to join you all today. This is a really challenging patient population with an awful lot of research and new management techniques that are being developed really every month. So I'm very grateful for the opportunity to kind of review some of these newer treatment options, diagnostic tools, and see how it goes. Oops. So I have no conflicts of interest to disclose, but I do want to acknowledge a very close friend of mine, Dr. Toby Steele. He's a rhinologist out of California at UC Davis. He has a special interest in empty nose, and he is the person that I call when I'm struggling with a particular patient. And he has a fantastic email address down there at the bottom. So in the talk today, I want to discuss the diagnosis of empty nose syndrome. I want to really try and understand and review the impact of this disease and its associated conditions, and then review emerging treatment options that we have to try and help these patients. First, I wanted to start off with a few examples of just how serious this condition is, both for the patients that are affected, as well as ourselves and our partners that are treating these poor patients. This is the title of a review that was published out of China, and it shows that empty nose syndrome may be the chief criminal behind many of the worst atrocities against rhinologic medical staff in China. Unfortunately, in that country, and I know we have several of our Chinese colleagues participating in this webinar, so if you have any insight to add at the end, I certainly would welcome it. I'm aware of two horrible events. The first in September of 2012, where a patient with empty nose syndrome attacked and stabbed multiple staff within a clinic in Shenzhen Hospital. And then the following year, in October 2013, the chief otolaryngologist at the First People's Hospital of Wenling was actually killed by a patient with a diagnosis of empty nose. So the Global Times of China covered this with a highlight of the title of the article, "Kill the Doctors." And this is really quite dramatic, especially for a field, we deal with obviously cancer, but an awful lot of quality of life. And you don't expect to see such unstable patients, such really severe occurrences. So this study reviewed online databases, patient records, and they found a lot of comments similar, I have listed at the bottom here, things such as a life worse than death, commit suicide, and again, kill the doctors. This is the unfortunate gentleman who actually suffered with empty nose and led to the murder of the Chinese physician that I mentioned earlier. He was a 33-year-old male, had symptoms of nasal obstruction, severe pain, and insomnia up to 12 months following an elective septoplasty. His treating physician evaluated him, found a very reassuring examination, patent sinonasal airways, no evidence of chronic inflammation or other treatable condition. He was subsequently, due to the severity of these symptoms, hospitalized by his family and treated for persistent delusional disorder. Following discharge, he then went and sought a second opinion from Dr. Wang. Dr. Wang evaluated and noted no need for further intervention, which unfortunately was what led to the tragic events. The patient represented a dramatic attack with multiple injuries, including, as I mentioned, the death of Dr. Wang. Patient was obviously subsequently arrested, stood trial in China, where he was found criminally liable and is currently seated on death row. So a real tragedy for everyone involved. So what is empty nose syndrome? It's best described as a clinical process. It's characterized by a paradoxical nasal obstruction despite an objectively patent nasal airway. Both of these images below are from a patient that we will go through their course at the end. But you can see in the coronal CT scan, they've obviously had reduction of the turbinates, huge intranasal volume. I mean, this is someone that you can imagine has tons of airflow and certainly should not experience symptoms of obstruction. Nasal endoscopy on the right side confirms CT findings where we see significant reduction of the inferior turbinate. It's marked by the star. And this is a patient where I describe, or I always raises my concern, where with nasal endoscopy, with anterior rhinoscopy, you can look in the front of the nose and see their nasopharynx. This is a huge patent airway. However, it doesn't really, that description that I presented doesn't quite cover the entire syndrome. Stephen Hauser, about 5 years ago, says that ENS is a poorly understood disorder. Reliance on pure anatomical analysis in the anatomy of empty nose fails short of explaining what's going on. And I completely agree. That prior patient that I just showed, that widely patent airway, well, that's fairly common. I mean, we treat, as I mentioned before, a lot of sinonasal cancer. We do large resections. And at least in my experience, the association with empty nose is extremely low in these patients. It seems to occur more in the chronic inflamed nasal obstruction, chronic sinusitis picture, rather than someone who needs to have large resections, has a huge patent nasal cavity, but for other causes. Just to put a patient perspective, this is wanted to mention UC Davis at the bottom. This is a patient of Dr. Steele's. He is an engineer, a PhD, accomplished, incredibly functional patient. And he sent this message, and I'll just paraphrase. He's been suffering from empty nose ever since a deviated septum and turbinate reduction surgery. He believes the root cause is the reversal of the direction of airflow. Essentially, your body has a new path of least resistance to get air into the lungs, cutting out the superior turbinate and pulling air directly through the airways on whatever the empty side of the face is. This causes the air to spiral down, going down first and then up, pushing into the lungs. He goes on in incredible detail. And when I first read this, my instinct reaction is this patient has a psychological disorder. To have such detail, such odd descriptions, especially for someone who's not a medical personnel, it raises red flags. However, if we talk about the pathophysiology and what we understand of this disease, he actually may not be that wrong. There's two theories that I'd like to quickly review. And on the bottom right, I have this icon of the panicking physician. I put this in every talk that I give, mostly because when I started as a junior physician, I licensed and purchased this icon. I spent $15 US on it. And so I feel compelled every talk I have to use it. So the first theory leading to empty nose syndrome is due to an alteration in nasal airflow and the humidification of air as it enters our lungs. The underlying event that leads to this disease is a disruption of mucosa, more often than not of the inferior turbinate. This causes a dramatic decrease in airway resistance through the nose, which is associated with an increase of air entering the lungs. This leads to turbulent airflow and ineffective humidification, and I would also posit filtering of the air. Baseline anatomy, our nose is a filter organ, and these patients with empty nose have disrupted function of that. Anatomically speaking, or physiologically speaking, the nose provides 60 to 70% of total air humidification to protect the lungs as you breathe. A total inferior turbinectomy decreases air heating and humidification by approximately 23%. So it's a significant alteration in our body's protective mechanism for the lungs. Patients with empty nose have significantly smaller turbinate volumes, which we all understand. And the size of the decrease, the amount of volume loss, is associated with worsening symptoms, nasal dryness, postnasal drip, facial pain, and thick mucus, all symptoms we may associate with this disorder. This can be seen with computational fluid dynamics. This is a really interesting study done out of the Ohio State University, where they look on the left side here. I hope you're able to see my pointer. These are patients who have undergone aggressive turbinate reduction, however, have no symptoms of empty nose. They're quite happy with their results. And they compare this to two patients undergoing similar surgeries, yet do in fact have symptoms of empty nose. You can see here in patient 5, there's actually decent volume of the turbinate here, especially compared to the patients without empty nose syndrome. So it's not clearly a volume caused disease. Now, when you look on the second row here, the airflow diagrams, blue is the absence of airflow. And then as you increase to the orange and red colors, that's increasing velocity. And interestingly, you do see significant differences in the pattern and velocity of airflow through the nose of patients without empty nose and patients with. So these images were all taken at the level of the superior turbinates. And we see in patients without empty nose syndrome, the majority of airflow is in the lower nasal cavity. Whereas in patients with empty nose, at the level of the superior turbinate, it's much higher. We see here in the middle aspect of the nasal cavity. So there is at least an association with altered airflow dynamics and empty nose syndrome. However, there's also a potential neurosensory defect. There's the TRPM8. It's a trigeminal receptor within the sinonasal mucosa, which is activated in the detection of nasal airflow. Loss of this turbinate mucosa leads to loss of signal transduction, loss of that signaling to the brain, which presents clinically as subjective nasal obstruction. So theoretically, these are patients that have fantastic airflow, but they don't have the equipment, the neural sensors to actually detect it. This was demonstrated by a really interesting study looking at specifically trigeminal function and testing the patient's ability to localize the side in which they're receiving a sensor, if you will. The investigators utilized menthol, which activates these sinonasal receptors and generates a cooling sensation. So it's not a painful test. And they went through 40 trials where they would alternate, randomize which side was receiving the menthol. The other side would receive a vehicle control, which would have no associated nerve activation. You can see 40 here is the number of tests that they did. So that's the maximum potential score. The controls, patients without sinus disease, received 34 out of 40 were right, were able to identify menthols on the right side or the left. No difference with patients that had a turbinate reduction but without symptoms. There's a small decrease, but not statistically significant. But you do see significance if you look in patients with empty nose, where they are an average of 21 out of 40 questions were correct. And you can imagine if these patients were just guessing, they would get 20 out of 20. So there appears to be a clinically significant decrease in neurosensation amongst these patients with empty nose. So it's complicated. We see evidence for both altered airflow and trigeminal defects in empty nose syndrome, which really makes management more difficult. But of course, before we get there, we have to diagnose the patients. There are a lot of different techniques that we have. The two I have highlighted in blue are the only that are validated and clinically used. The rest, CT imaging, fluid dynamics I presented, and trigeminal nerve function is really either not valid, such as the CT, or the other two is reserved for the research setting. So the two I want to focus on is the ENS6Q. It's a validated patient-reported outcomes measure, and then the cotton test, which is a test that we can do endoscopically in the clinic. So ENS6Q is presented here. It was developed out of Stanford by Dr. Nyack, who has done an incredible amount of work in this field. He really, I would say, is the thought leader for the treatment of these patients. This test is broken down into 6 different symptoms with a range from 0 to 5 on a Likert score. A total score greater than 11 is suggestive of empty nose versus sinusitis. So it's very helpful in the screening phase to identify, does this patient potentially have empty nose syndrome? The minimal clinically important difference has also been defined, which is very helpful in us not only diagnosing, but then following outcomes of this disease. So a change of points greater than or equal to 7 is clinically significant or identified by the patients. The cotton test is, as I mentioned, about a 30-minute procedure that we do in the clinic. It is shockingly easy and shockingly effective. If you haven't done it before, I really would recommend giving it a try. It's incredibly well tolerated. You take a patient who has not been anesthetized, their nose has not been sprayed, you take a small piece of dry cotton and place it right in the anterior aspect of the inferior turbinate. You can see here in B and D, we have the little bit tucked under the inferior turbinate and a little bit extending anteriorly as well. And this is purely a mechanical test, which is altering the nasal airflow and seeing if the patients report improved symptoms. You wait 20 to 30 minutes. Many of the patients will tell you a difference within 5 very quickly. And then you evaluate their change subjectively. Do you feel better or not? If you want to really use the validated system, have them complete that ENS6Q before and after the procedure. No matter what their baseline ENS6Q score is, if it improves by more than 7, that's reflective of a clinical difference and a diagnosis of empty nose. Again, is very easy and straightforward. So how do we manage this patient? We've identified, we suspect that they do have empty nose syndrome. Well, before we get there, the expression, an ounce of prevention is worth a pound of cure. There are some guidelines to follow surgically to do your best to prevent this condition. As I mentioned, the greater loss of turbinate mucosa, the greater the risk for having empty nose syndrome. A guideline I try and follow is to preserve 50% or greater the inferior turbinate if I can. Of course, in cases of sinonasal cancer or other conditions where you have to remove more tissue, I certainly will. I don't hesitate when it's clinically indicated. However, in the age of submucosal turbinate reductions, which hopefully we all are familiar with, the need for resecting entire inferior turbinates just is not there. Humidification is a first-line treatment strategy. Things like nasal saline gel, saline irrigations, bedside humidifiers all have subjective improvement in patient symptoms, although very rarely will it completely manage or cure their condition. And then there's the role for surgery, which we'll talk about. So one question that I had that I think this study in particular really does a fantastic job of answering is, what is the role of middle turbinate preservation? And when I was training, I had faculty who really warned us, protect not only the inferior turbinate, but the middle turbinate as well. And we don't want the patient to have empty nose. And PJ Wormold out of Adelaide did this prospective cohort examining patients undergoing FES with a partial middle turbinectomy versus patients where the middle turbinate was preserved. And they found no significant difference in pre and post-operative quality of life, no difference in the development of empty nose syndrome. So the authors conclude that a partial middle turbinectomy did not increase patient risk for empty nose, and really is something that gives me confidence as I resect middle turbinates for inflammatory conditions. So surgical management predominantly depends on turbinate augmentation. You essentially are trying to replace lost tissue. Now, again, this is not going to address the neurosensory deficit that we found in patients with empty nose, but this will directly realign or redistribute nasal airflow. Given the severity of this condition, there is great interest, but the level of evidence is still relatively low, predominantly small case series currently published. These procedures vary, predominantly utilizing either autologous cartilage or biosynthetic materials. I have a lot listed here. And the goal, again, is to augment or to create a pseudoturbinate. The injection site has been reported as either the lateral nasal wall, but also turbinate stump, septal region, even the nasal floor. So there's still some evidence, which I'll present, but not a universal consensus as to the most appropriate injection material or the most appropriate site. So I utilize ProLarynx. It is a carboxymethylcellulose gel that my laryngology colleagues utilize for vocal cord injections. It lasts about 3 months, so it's not a permanent procedure, but gives you a really significant amount of time to evaluate outcomes and if this does in fact improve patient symptoms. So the largest systematic review was published 5 years ago, so it's a bit dated now, but the authors identified 8 studies with a total of 128 patients, and they identified significant improvement in SNOT scores following the procedure, up to 12 months of follow-up. They note that the early findings, what's available in the literature, is promising, but they highlight the lack of adequate power in control groups. This is by no means the end of the story. So they're able to break down the benefits either in the SNOT-22 domains on the left side, these first 4, or in empty nose syndrome symptoms. They report in blue the maximum reported score, which is not the immediate preoperative score. And they compare that to, in the middle here, the preoperative score, and then the postoperative score at 12 months. So there's significant differences really in all symptoms, all domains here, with largest being changes in psychological issues and empty nose syndrome symptoms, all of which are patient self-reported. What I think is really fantastic is not only are you able to generate patient-reported benefits, but this is actually reversible. So the ProLarynx that I mentioned dissolves over the first 3 months. And in this study out of Stanford, you see they inject here at the lateral nasal wall to create this pseudoturbinate. And their ENS6Q scores decrease significantly following surgery, with over 3 months, a slow reversal back towards baseline. So it, in my mind at least, speaks to the specificity of this benefit and that it is a true physiologic change that the patients are appreciating. So the next question that I think we should ask is, well, where do we inject? I mentioned 4 different sites. Presumably all 4 sites are going to significantly change airflow. So what is the best? And there's only one study that I'm aware of. It was published in 2018, and it evaluated 30 patients over a 5-year period. These patients were roughly equally distributed and either received augmentation of the nasal floor, as you see here on the left, or on the right, the lateral nasal sidewall. In the center here, they're showing the inferior turbinate stump, which could also be injected. They evaluated outcomes at 12 months and find a superior benefit at the lateral nasal sidewall. So this is the area that I inject when I do this procedure. The, excuse me, they report score improvements in each domain using the SNOT 22, and you see significant improvements or the greatest improvements in both the rhinologic domain and the sleep domain here. Interestingly, the psychological domain does significantly improve, but not quite as much in the systematic review that we presented earlier. So the elephant in the room is, what is the role of mental illness? You know, this is a condition that I think, as many of you know, is argued about at meetings where respected minds say this disease does not exist. This is a somatic disorder. The evidence that they are presenting is that 2/3 of patients with empty nose screen positive for moderate depression and anxiety. I think a very fair question to ask, is this a result of the disease? Is it a chicken or the egg type symptom or situation? And of course, in all patients with sinus disease, comorbid depression is associated with worse baseline symptoms and worse surgical outcomes. So it really is a challenging situation that we have where our patients, either because of mental illness or because of empty nose syndrome, are very difficult to treat and to cure. And of course, I present this as a joke, but there's similar percentages of patients, millennials, living at home with their parents. So there may be many factors at play here. So this question of somatoform disorder, you know, there are very high rates of depression and anxiety in this patient population. Mentioned 2/3 up to 60% of empty nose syndrome patients, but also up to a quarter of patients with chronic sinusitis. This psychiatric illness negatively impacts our surgical outcomes. So my unsolicited advice is every patient that you see in clinic with chronic sinonasal disease may benefit from screening for psychiatric illness. They're validated surveys, I'll mention one in a moment, that can just help facilitate referrals to a healthcare provider so that we're treating not only the nose, but the entire person. So this is a brief example of recommended management plan. A patient comes and presents with symptoms suggestive of empty nose. You're going to take a comprehensive history and exam, including surgical history, diagnostic nasal endoscopy. I then hand them the empty nose 6Q questionnaire as my screening tool. On the right side, if their score is greater than 11, that's highly suggestive of empty nose. However, if it's less than 11, if it doesn't screen positive, well, if my index of suspicion is high enough, I'll still proceed with the cotton test. If the cotton test improves their symptoms and they say, that's great, I feel much better, then I go back over to suggestive of empty nose. If both your ENS 6Q and cotton test are negative, I would consider other causes. It's highly unlikely that they're dealing with ENS. And then again, if either or both of those tests are positive, I will then proceed to screen for mental health comorbidities and discuss treatment options, almost universally leading to a turbinate augmentation. So here's an example of one of these patients. This is a 42-year-old male presented with a complaint of I cannot breathe through my nose and it bleeds too. Now, I didn't mention epistaxis as an associated condition with empty nose. I included here to highlight that these can be complicated and you have to really have a decent index of suspicion to identify empty nose and not be thrown off by other symptoms. He has a history of septoplasty and turbinate reduction 2 years prior and is currently using fluticasone twice a day. So here's the nasal endoscopy. Right side and the left, we see evidence of the prior inferior turbinate resection, but it is not that entire turbinectomy. You know, we don't see the nasopharynx anteriorly, as I mentioned earlier, but clearly he's had surgery and is missing tissue. So perhaps empty nose may be at play. And we ask what is missing. Some people describe it as the head of the torpedo. And we see on the right side, the inferior turbinate here, posterior half is intact, but that head of the torpedo is what we would like to augment and replace. So what are the next steps? Screen with the empty nose questionnaire, scored 21, so greater than 11, possible empty nose. Then proceed to a cotton test to confirm, and within minutes, says, I feel great, you fixed me. Can I go home with my cotton? Score went down to 8. Following that, we gave him the mental health screen, which is the PHQ-9 score. He reported 18, which is highly suggestive of moderate to severe depression. Now, again, this does not help us with the chicken or the egg, but it does clearly show that he's suffering from more than just sinonasal symptoms. So I absolutely refer this patient to one of my colleagues in psychiatry to help engage this patient throughout my treatments. We then perform a turbinate augmentation, and this is a video that Toby Steele offered to share with us. It was a patient that he augmented. This is done in the clinic. You'll see the patient moves around a little bit, and let's take a quick look and then I'll highlight some take-homes. See, we're on the right side here. Again, the head of the missile is missing. Injecting first in the sidewall, and then here at the stump, if you will, the attachment point of the inferior turbinate. This is with prolarynx. A total of 2 cc's were injected at the 2 sites. It's important when you do this, and you'll see right there, when you remove the needle, some of the material extrudes. So it's important to really do your best to minimize the number of injection sites. The more times you stick the mucosa, the more prolarynx or whatever other material you use, more of that will extrude. So this is done at the bedside following cotton test, if you like. I will inject first with local to anesthetize, give them a few minutes, and then I'll inject either 1 or 2 cc's of the prolarynx material. This is the patient 1 week post-op. See their empty nose score decreased to 10, which is fantastic. And we see some augmentation, some swelling here, which is still pale. You know, the mucosa is still accommodating the increased tension, but he's doing very well at this point. 3 months, now this is back to the time of degradation of the prolarynx of the injection material. And you see the empty nose score is back up to 18. So 3 months later, we are essentially back where we started. If patient would like to proceed, you can inject again. You certainly can consider other implantable cartilage, other longer lasting gels. It's really completely up to your comfort and what you think is best for the patient. So case study 3, I wanted to present a quick patient from my own practice to wrap things up here. This is a 54-year-old male that I know extremely well. He presented to me initially after having seen a number of outside providers with a chief complaint of, I cannot breathe through my nose and I'm depressed. My heart really goes out for this gentleman. He is just a very flat affect. You don't have to ask if he's feeling down. It's written all over him. So of course, given just those 2 chief complaints, I'm concerned for empty nose. His past surgical history is inferior turbinate resection and endoscopic surgery 2 years prior. And he's currently utilizing budesonide irrigations twice a day. And empty nose, I highlight as being much higher than 11. This is one of those patients, and I'm sure you all have them as well, that takes the right side of the survey and just circles everything. It's as bad as it can be. He reports a 30 out of 30 on the empty nose scale. So this is our nasal endoscopy here, which surprised me a bit. So we clearly see evidence of significant inferior turbinate resection, but we also see this mucopurulent drainage coming from the middle meatus. And likewise on the other side, interestingly, we see a big septal spur. You know, that's extra tissue. You could think that's compensating for the turbinate resection on the right, but likewise, there's also mucoid drainage from the maxillary. So what is going on? If we were all in person, I'd call on someone who was asleep to really, to take us home. But I put a red star here. This gentleman does not have empty nose syndrome. He is clearly depressed and has chronic sinusitis. He has recirculation. His natural ostia were not connected to the maxillary antrostomies, which we see further back. And I'm actually next month taking him to the OR, very hopeful that by correcting this scar band that he has bilaterally, that we'll be able to improve his symptoms, hopefully in working with our psychologist as well, that we can really benefit him long term. So that is it. This is my daughter Margot, who says hello to everyone, and thank you all for participating and for this opportunity.
Thank you, Joshua. First of all, because you started your presentation not by talking directly scientifically, but reporting what is the truth and what is the problem that's suffering from people that are thinking or not thinking. I mean, those ones that are really suffering from empty nose, and what's the threat, what's going to be not only their problem, but also what can affect their life and other people's life. So by meaning of that, we will start with the questions. Some of them are from over here, some of them from other Facebook and YouTube. We don't have enough time, but just want to point one thing. In 2015, I remember while we had Professor Stamberger, rest in peace. I remember that he started his talk in Milano Masterclass. And we were delighted that he has a talk on inferior turbinate. And he received just 2 days prior to the Milano Masterclass a letter from some organization, which was ANSIA. And I've also been contacted from there, which they were talking exactly about the empty nose syndrome and how much impact they had on their life. So by meaning of that, empty nose syndrome nowadays, after 4 years, is becoming one very important topic that we have to discuss and to take care and take of interest. And not only because of treating patients means increasing the awareness and the importance of being not a turbinator. That was the talk about him, about Professor Stamberger. But we also have to think about to save as much as possible mucosa, because if we're sparing or if we taking care of those important structures, which is the mucosa, in fact, we will preserve a lot of component that we have to take care. At the same time, the importance that you raised was exactly the mental behavior of such patients. Sometimes this is not just a problem due to olfaction or breathing. This is just also a mental issue that they have. So this is in fact one of the issues that facing of the plastic surgeon or the people that are doing rhinoplasties. They also always referring to a psychologist. But we have to go ahead with the questions. The first one is coming from Portugal, and the colleague is asking, can be a septal perforation a causes for empty nose syndrome?
Yeah, that's a really fantastic question. Specifically since we're talking about alterations in nasal airflow being associated with this condition. In my experience, and as far as I'm aware, and please let me know if you have a different view, I have never seen it reported. In fact, there's some literature that shows, and this doesn't directly relate one way or the other, but some perforations are treated by a posterior septectomy. So you remove the posterior aspect, which is generating the turbulent airflow, and patients do incredibly well. So yeah, that's a very thoughtful question, and I am not aware of that association.
Okay. Another questions is coming from one of the colleagues that is here. Does the bipolar diathermy using reduction of inferior turbinate lead to an ENS?
So theoretically, no. It's submucosal reductions. The whole goal is to preserve that mucosa, preserve the neurosensory function and volume. It is possible that a patient will present with empty nose following that. But again, you would be struck by lightning to have a patient come in after that conservative procedure.
Another question, their doctor would like to kindly ask you whether there is a significant difference between ENS and atrophic rhinitis.
ENS and
atrophic rhinitis.
Oh, atrophic. Atrophic rhinitis, I don't think is studied well enough. We have a lot more understanding of the pathophysiology of empty nose. Atrophic rhinitis, their theory that cilia is disrupted, you have atrophy over time, obviously, but I think there's a connection in that there's the potential for change in airflow, but really in atrophic rhinitis, I think of similarly to chronic sinusitis, where you have loss of ciliary function, mucostasis, leading to more symptoms.
Okay. Another question from India, and these colleagues is asking, could be a medicamentosa rhinitis due to cocaine lead to an empty nose syndrome? I think they're pretty much the same question, but however.
Yeah. And certainly I think it's possible. Significant intranasal necrosis, loss of tissue is certainly associated not only with cocaine, but in other opioids, patients that are inhaling, it can present almost looking like invasive fungal disease. So certainly it's possible. I would say it's on the rare side, and I personally have not seen any patients presenting in that way.
Another question from Mexico is this colleagues is asking, does an implants works on empty nose syndrome? By meaning of that, I also would like to tell that I've been contacted from many people. They're asking a different doctor that using implants. I didn't realize what was exactly their question. I mean, implanting what on what? And if we don't know exactly the cause, and this is because they might have an inferior turbinectomy and a concomitant septal perforation of whatever it is, I would like to ask from you, what's the implants they might have taken care of?
Yeah. So I think we had to rely on our facial plastic and reconstructive colleagues to really borrow their expertise and the substrates that they use for implants. Things like MedPore or nasal septal cartilage, if it's available, both can relatively easily be implanted in a pocket on the nasal sidewall. The concerns that I have, it really has to be a very compliant patient, someone that I know will follow up with me regularly, and that has already, in my practice at least, benefited from the temporary injection. I start with that to see if they benefit. My only hesitation with the more permanent implants is that there's a higher risk of them developing infection, other sequelae long-term. That being said, if they do have a site infection, that's easily treated. This is, things that could be done presumably in the clinic with the right patient. So it's something that I've only done twice, actually. Both cases, I took them to the OR and utilized nasal septal cartilage.
Another question from Pakistan, and this colleague is asking, what's the meaning of nasal cycle?
Sure. So the nasal cycle, as I understand it, is a alternating neurologically mediated occurrence where one side of the nose will congest while the other will decongest. Happens every hour or so, and they'll alternate side by side. We see this clinically all the time in patients with allergic rhinitis or turbinate hypertrophy. They say, when I lay down, I have to roll over to open my nose, or they'll even say one side, then the other. back and forth. What I described to the patients is this is a normal phenomenon. It's happening in all of us right now. The difference is, at least thankfully myself, my nose isn't inflamed enough that I notice it. In your case, the patient presenting, describing this, because of the allergy, the inflammation in your nose, you don't have enough room to accommodate that cycle, and it becomes symptomatic for you. So it's something, the rationale or the reasoning behind this cycle isn't very well known. I posit that it's related to clearance of mucus secretions. However, it's not very well studied.
This is a question from one of the colleagues from China. It doesn't explain very well what's his meaning, but however, and he's asking, can it be associated or can be lead to I don't understand. There's something wrong with his spelling, but I think that was he would like to ask is could be assessed as a crime doing turbinate surgery nowadays. I think that
he's trying to get me in trouble. I think
express that. Yeah, I think.
No, you have to recognize that there are indications and times when a turbinate has to be removed. Medial maxillectomies, I mentioned cancer a few times, things like that, certainly. But even in inflammatory conditions, I think we all have seen these patients who have widely patent maxillary sinuses that just hold pools of pus, CF patients, things like that. So I think I agree with the thought behind that question. And in my practice, I actually follow that. I actually don't enjoy doing submucosal reductions. I think the benefit is somewhat short-lived. It really has to be a clear symptom and a clear cause of the patient's issues for me to intervene surgically. However, there are times and indications where you do have to resect. And the same is true also, I want to make sure I was clear when I was talking about the middle turbinate. I do everything I can to protect the middle turbinate, even in inflammatory conditions. But when I have a case where I think it's somewhat lateralized or it may inhibit the patient following surgery, then I will do a partial middle turbinate resection with the confidence that it has not been associated with empty nose.
Sure. I mean, this is completely normal to make studies and think about the importance of the middle terminate. Even if for the superior terminate, we had so many studies on preserving the superior terminate for sphenoids, sinus surgery, for sphenoid surgery, for approaching for the sella, and stuff like that. This is important. The important thing is to make studies to see how much is the impact on the breathing, but nowadays, due to electronic devices, to augmentation, we can also extremely detail analyze the airflow. And as you reported in your presentation, the importance of the middle terminate sometimes, not always, for sure, sometimes is not so important to developing such a condition like an empty nose syndrome. We are not discussing, I think, about the importance or not of the middle terminate. For sure, this is important, but we have to keep in mind that preserving something that is completely unnatural, which can be caused because of the polyps and the degeneration, sometimes cannot be preserved, but however will not lead to a condition such as empty nose syndrome. So after all these questions, last but not least question from the audience is that have ENS patients have reported that symptoms change several times during the day? For example, nasal cycles, swollen mucosa, burning sensation, dryness, ear pain, facial pain. Is it due to the altered nasal flow?
That's a great question, and I'm not aware of it being studied before. I can tell you in my clinical practice, the patients are so symptomatic and so severe. It tends to be that patient type that circles the right side, worse as can be all the time. but I think that's a very interesting thought that should be studied.
Sure. Thank you, Joshua, for being with us. This topic will be recorded and we'll deliver it on our YouTube channel. We will have Joshua Levy once again part of the ARS Junior panel because since 2020, due to his cooperation and to other colleagues and friends that lead to a collaboration interactive with the ARS, we will have also an ARS Junior panel on May 15 on Friday. So thank you, Joshua, for being with us. It's much appreciated your intervention. I will announce the second appointment for the 1st of February, Saturday, with Liliana Jovancevic from Serbia. She will talk about olfaction in neurodegenerative disease. I will would like to congratulate you for your presentation, and I'll see you for the next appointment.
Thank you all. Have a great day.
Bye.